The next speaker is Dr. Tony Wierzbicki from King's College London. I always liked Tony's presentations, which are quite provocative, and I like the sort of analysis, and he always finds an angle to actually caution us about the paradigms and dogmas that we tend to use. So, Tony, tell us about what beyond statins in terms of LDL reduction, what's on the horizon?
Oh, thank you very much, Juan Carlos. It's a pleasure to actually speak after Kosh. Kosh has told you why statins are history. I'm sure the Daily Mail will be out there banning them tomorrow. On the other hand, for our pharmaceutical representatives in the audience, hey, it's Christmas. And what I'm going to be talking about is what do we do beyond statins? On a more serious note, statins are basically the number one drug for prevention. They work in everybody. And as Kosh has rightly said, the diabetes story is grossly oversold and is used by the statin skeptics now that they can't say that they make you jump underneath trams in Finland, I think. Sorry, that was fibrates. So the whole thing about this is that we have risk. We have a large amount of lipid risk. And OK, InterHeart is a cross-sectional cohort study, so it does likely overrepresent the risk to lipids. And we also know the incremental benefits of lipid-lowering drugs. These are the meta-analyses that we've all seen before, effectively about a 20% risk for every extra millimole, and that's on the conservative side because of placebo drop-in. And the higher dose therapies offering us a little bit of extra, but not a huge amount. So most of your benefit you get with the lowest dose of statin, so it helps to start with a nice powerful one at low dose. And if we look at the best measures of lipid-related risk, well, we all know these. These are the total cholesterol triglycerides. I'm a personal fan of non-HDL. I think we underuse it in the UK. Given that we have an epidemic of diabetes and an epidemic of obesity, non-HDL is far better. It doesn't carry a lot of the disadvantages of actually calculating LDL, which the NHS does on grounds of cheapness, and is nevertheless based on a total data set of 132 patients, 22 of whom had diabetes. That's where the Friedwald equation comes from. And they were diet-controlled diabetes, by the way. So, not very good. So, truths and suppositions. Targets are the outcomes of most of the trials. Truth. Well, actually not. Every single guideline in the world has a target. Which lipid-lowering trials actually had a target? 4S. That was the only one. And maybe Greece, but Greece was always underpowered. Every single other one didn't. They were all drug X versus placebo. Further LDL reduction is better. Well, yes, but the high-dose relationship is a little bit aberrant. Some of the trials that we had, normally, if you actually put this graph up, and I put it up for hope, progress, and peace in the glucose of ACE inhibitors, highest risk patients should show the same relative risk reduction, therefore the greatest benefit. Actually, for statins, the relationship's the other way round. Biggest effect was seen in TNT, the first study, which is actually the lowest group event. This all came out in the wash in meta-analysis, but does actually suggest that there are other things going on, and it might not be quite as simple as we actually think it is, because actually the changes in lipids weren't that different. And what should our target be? Well, if you draw nice straight lines, well, 50, 60 milligrams per deciliter. If you draw curves, 2 millimoles per litre. And then we get on to residual risk. If you can't actually do something about what people are doing at the moment, you always say, well, it doesn't do everything. So let's get some residual risk in there. And this is what has been being sold over the last 2 or 3 years, that there is residual risk. But what drives it? It's got to be cholesterol, hasn't it? Well, no. There's thrombotic events. There's actually psychological events, a lot of depression-related cardiovascular, how that actually manifests. We don't know. We know that the antidepressants don't do anything about it. But nevertheless, there is a whole load of risks. Posh has talked about the glycemia risk, but there's thrombosis associated with it, which we underestimate, particularly in diabetes. Inflammation-associated risk, which we underestimate. Should we actually be using better anti-inflammatories? Paul Ridker's methotrexate trial, low-dose methotrexate trial, might actually give us an advantage. New agents like canaluminab, the IL-2, IL-1 beta agonist, might actually also give us data there. And all of this is to stop the 50 to 70% of risk not prevented in 5 years in trials. I don't think that's all going to be lipids. However, there is one group that always does worse, and that's diabetics. And if you actually look at reversal, this is one of the IVUS trials, you can see that just comparing the type 2 diabetics on progression versus regression, they always progress more, and they don't regress. They still continue progressing even on the highest doses. So in our ultra-high risk groups, particularly type 2 diabetes, and all of these were 10 years plus diabetes, so the very high risk form that Kosha's mentioned, we will be looking at people that will still get progression of atherosclerosis. So what else can we do? Well, I'm going to talk a number of agents. Ezetimibe might be thought of as an old drug. Well, actually, we still, after 10 years of having it almost, we still don't know what it does. We still don't know whether it works. And sometimes those trials don't really help us. Mipomersen, MTP inhibition, PCSK9, I'll come along now. If we actually look at the ezetimibe trials, they've been done in chronic renal disease where moderate dose statin trials have done nothing. So the 20 milligrams Atorva reduced LDL 40% in 4D, did nothing. In Aurora, it was 10 milligrams of rosuvastatin, again a 40-odd% reduction in LDL, no difference in events. Sharp, we again saw an LDL fall this time of about 30%. Actually, a lot less than we'd expect, given that we were using Timber 20 and ezetimibe 10. We get normally about 50 for that, is what we do. 50 to 60 is what we expected. And we saw a modest reduction in events. So is it the population? Have we got our heart failure problem that actually in chronic renal disease, the events are not actually atherosclerotic, they're not atherothrombotic, they're actually caused by different mechanisms. And we've been misclassifying over the years as we did in heart failure. We don't know. That was certainly a trial that certainly a similar thing can be said about the SEED study, where, again, ezetimibe was given with a statin. We got a small reduction in CV events. The trial was underpowered, too small, so it wasn't significant. But if you actually look at the data that's come out on aortic stenosis thereafter, many of those patients actually had significant left ventricular fibrosis and actually showed increased incidence of dysrhythmias, even at what we thought, when John Chambers and Terry Paterson and myself and a few others designed the trial, thought was going to be a still normal heart population. So the problem with ezetimibe is it's the wrong population in the trials. And will improve it tell us? No. It's underpowered. And basically lipid lowering in acute coronary syndromes is a long-term benefit, not a short-term benefit. The short-term benefit is mostly driven by antithrombotic effects. So what else have we got? Well, we can attempt to target all the areas of the ApoB pathways. So we have the whole group of cholesterol sensing in the endoplasmic reticulum, the SREBP2, which is a steroreceptor binding protein, which drives transcription of a whole load of cholesterol upregulating genes, like all the cholesterol synthesis pathway, plus LDL receptors. And that's a lovely set of work that's actually distinguished that. ApoB is produced, ApoB goes to the ER. It's only stabilized if you add phospholipid and then triglycerides and cholesterol to it. And that's the role of MTP, and there are a number of enzymes also involved there, and this makes your nascent VLDL. So we can actually attempt to target various aspects of this pathway. Now, the first one I'm going to talk about is small interfering RNAs, and that's the first drug in that is Mipomersen, which remarkably you give as a sub-intradermal injection, migrates to the liver and actually downregulates ApoB. And it seems to work. And this is Mipomersen given every 2 weeks. This is the dose ranging study showing that we get LDL reductions of about 40% and ApoB reductions of about the same. This dosing was actually carried on all the way up to 400 milligrams, and the levels were reducing by about up to 80%. So that was the original proving trial. If you give it in homozygous FH, so there are no functioning LDL receptors, and statins tend to either not work or work very poorly in homozygous FH because they're dependent on LDL receptors, expression of LDL receptors for their function. You can see that we get very, very successful reduction of ApoB, LDL, and also LPA. And this is in a population with total cholesterol around 11, LDL of 10. And you can see from the drug therapies, statin, maximal statin or statin combinations, of which 76% were on ezetimibe. And 62% were true homozygotes, 20-odd% were compound heterozygotes. So this was Fred Rahl's study showing that Mipomersen worked. You can give it in moderate hypercholesterolemia, and you get a bit more of an effect. You're getting reductions of about 60 to 70% at higher doses, even given at 400 milligrams per week. So they tend to respond a little bit better than the patients that we'd seen previously with homozygous FH. So mipomersen, which is currently in trial in the regulatory agencies, looks wonderful. However, where is the data on the myocardial infarct and cardiac events in those trials? Have a look at it. It's flat or actually against. Very underpowered. But with those kind of cholesterol levels, it should be going down and down significantly. So what else does mipomersen do? Well, actually, it's a very strong, like many of these oligonucleotides, a very strong T-cell activator, particularly Th2 lymphocytes. And Th2 lymphocytes are known to be involved in atheromatous plaque and may be actually involved in making some of the cytokines that actually trigger evolution of plaques. So we might be counterbalancing the LDL reduction with a pro-inflammatory effect. And the only way we're ever going to find that out with mipomersen is do a trial. And that's why we need a long-term outcomes trial with this particular agent. So that's mipomersen. Probably we'll get a homozygous license, but we will need, and certainly it has been looked at for getting orphan licenses, but we need more data. What about microsomal transfer protein? This actually is involved in loading triglycerides and cholesterol onto nascent ApoB. These drugs have been around for about 15 years. This is the original study from Marina Kushel. This is lomitipide, which was an old BMS drug. It's now run by Gerion at far lower dose. And you can see it's very successful at reducing LDLs by about 60%, ApoBs by about 60%. It'll also reduce triglycerides by about the same amount. The problem is on the right. It's the ALTs. And those are going up dramatically. Some of them are 5-fold elevations. There's no bilirubin change, so it doesn't make Hy's law. But the hepatic fat increased on over 20% in these people. And this was a 4-week study. We now have data on the expanded population, which is Maria McGowan's group, so it's the same group, looking at mipomersen in severe FH. You can see the lipids there, maximal statins, statins, very similar to the data I previously showed you, slightly less severe, and the times of falls and reductions are of the 40-odd% range for both ApoB, LDL, non-HDL. So it is definitely working, and this has just gone online. Again, very little on events in that study. Again, small numbers, so it comes with a huge warning. The hepatic fat data is on the bottom. You can see about 10% increase, and we have transaminase increase. You can see approximate doubling right across the group. So what are we going to do? Is this drug going to cause fulminant hepatitis? We don't know. Is the drug at risk of causing fulminant hepatitis? We don't know. However, if you are microsomal transfer protein deficient and have hypo-beta, you run abnormal transaminases quite often. You have elevated liver fat almost universally. Do you actually get cirrhosis? No. What's the second hit? Probably inflammation. So the warning will probably be with lomitipide, is there inflammation involved? Because if there is inflammation involved, then you might be able to start the process of NASH and therefore the risk of long-term problems. PCSK9 is the newest kid on the block, and like the newest kid on the block, they are always the most popular. Everybody wants one. What is it? It's a regulator of the LDL receptor. What is its purpose? Probably to suppress LDL receptors postprandially so you don't get a fatty liver immediately you've eaten. So that is probably its actual role. It is actually highly involved in the control of the menopause and menopause lipid levels and andropause lipid levels, and also with adolescence and menarche. So we know that there are controls from gonadotropins and sex hormones are involved. We've known that the activators of PCSK9, the homozygous autosomal dominant mutations, cause familial hypercholesterolemia. And we have, on the other hand, we have patients who have deletion mutations, particularly in African Americans, and we know that they run LDL levels about 0.3 to 0.5 millimoles lower than the general population, and they have a lifetime reduced cardiovascular risk of about 70 to 80%. So the data is quite strong both ways for that. So what happens if we try and inhibit it? Well, there's a number of ways of doing it. We can try a small molecule inhibitor. PCSK9 actually works as a dimer. It is actually autocatalytic, and it is quite possible probably to make a specific small molecule inhibitor because it's a highly specific autocatalytic enzyme for itself. And there's only one company working on this in Boston, but that has only got to phase 1. You can make antibodies to it, and there are numerous candidates. I know of at least 5 there that actually can make, and those will remove systemic PCSK9, and I'll show you the data later. Then we can take the antisense approach we took for mipomersen, and we can knock out PCSK9 inside cells as well as in the plasma. And in the liver, there's an internal PCSK9 pathway, intrahepatocyte pathway, that also regulates LDL receptors. And these are the compounds from ISIS. There's Santaris, have one. There's about 3 or 4 others as well. Let's take the first data that was published. This is on Regeneron 2727. The data is pretty much equivalent for all of them. And you can see that we're actually dropping LDL levels by about 50% and ApoBs as well by about the equivalent amount. So in dose ranging studies given every 4 weeks, it is as effective as mipomersen. This is a recent study from the New England Journal looking at 92 patients on LDL-C, and you can see, again, like the studies that were done in the statin intolerance, the polygenics, we're getting about 75-80, so very similar to what we see with mipomersen as well. And this was on the background of a statin. This is the latest data shown a couple of weeks ago. This is another one. This is AMG 145. This is the Rutherford study. Again, looking at people with a mean LDL of about 4. So these are general groups. And you can see that the reductions we're getting 50-odd% again, added to a dose relationship. And a great course for statin intolerance, where you need to sell something to the investors because you're going to give it to everybody, aren't you? Well, no. Please remember, statins are effective even at low dose. This is a study of 10 milligrams of pravastatin, i.e. practically homeopathy. This is just your shiitake mushrooms with a light flambe. And this was the Japanese doing it. And you can see that even giving 10 milligrams over 5 to 10 years almost actually made it on total mortality, 28% reductions. So even at 10 milligrams with pravastatin, i.e. microscopic doses, we still see an effect. You can dose statins intermittently, and we've done it, and plenty of other people have done it. You can even use drugs like rosuvastatin 5 milligrams once a week. Drug companies hate it. PCTs love it. It's cheap. Actually, AstraZeneca have done an 80 milligram once weekly trial. 40 milligram once weekly trial. It's effective, gives you about 45% reduction. So what happens if you give a statin? Well, so you give PCSK9 inhibitor, this time in FH. Again, you get your dose relationship. No surprise there. All PCSK9s are the same, but what is our safety data? Our safety data is a total of 3 homozygote PCSK9 deficients in the world who are all supposedly healthy. Maybe. I'll believe it when I see it. If you give PCSK9 if you look at a PCSK9 knockout mouse, what do you see? You see hepatitis, you see pancreatitis, you see disturbances in bile acid function. Does it happen in man? We don't know. We'll only find out when we give it to far larger numbers of people. Now, HDL is not the topic of my talk. And we've been trying this hypothesis for a little while, adding HDL raising agents to LDL lowering agents. HDL is complex and far, and I know you've had lectures on it this morning. But please remember that drugs like niacin don't just raise HDL. Niacin reduces LDL. How it reduces LDL, we don't know. 50 years of work we've had on niacin, we still don't know how it works. Probably it's a DGAT2 inhibitor. So it's actually reducing VLDL synthesis by actually working at an earlier stage in the MTP, before MTP inhibitors, to actually stop triglyceride loading of particles. That's the best guess, but that's only a guess. We still don't really know. We know that it reduces LDL quite effectively, 20-odd%. That's the same roughly as pravastatin does. But do we, when we add it to a statin, an OKM high was underpowered, but we didn't see anything. Not after 5 years. We'll need the data from HPS2 Thrive to actually look in more detail. But there's the LDL effect. There we are, 5-6%. And aim high was confounded by the ezetimibe drop-in. So that is an underestimate of the niacin effects on LDL there. Fibrates, do they lower LDL? A bit, about 5%. To prevent non-fatal MI, don't do anything else. I think fibrates are a bit old hat. We've now got beta delta and alpha gamma in development. Probably they will work if they change lipids, but we don't really have. But the only data we have for adding them to a statin is a cord where they didn't do anything. So should we add them? And if so, whom to? Should we be looking at the dyslipidemic group? That's what the FDA thinks. The high trig, low HDL group is where we should actually be looking for fibrates, because they change the quality of LDL particles, not necessarily their number very much. And lastly, CETPs. Everyone thinks CETP inhibitors raise HDL. Well, they do. That's their design characteristic. But what happens if you raise HDL? You actually, in humans, lower LDL. And torcetrapib lowered LDL very successfully by about 20 to 30%. What it didn't do was actually significantly change flux. So if you're actually looking at fecal sterols, and this is fecal sterol production, so this is fecal sterol exit, you can see with a torcetrapib added with a statin, you get increase. Torcetrapib on its own, nothing. And torcetrapib increasing cholesterol production in the liver. So it's basically shuttling lipids in the plasma. Given the data on dalcetrapib, one could actually say it was shuffling deck chairs on the Titanic. Because that's what it did. It shuttled the deck chairs from one side to the other side, and the ship still went down. And torcetrapib went down, but that was for different effects. That was an endothelin-1 antagonist, etc. But nevertheless, still suggestions of slight benefit. Dal outcomes, we know, was recently published. It was published today online, or rather yesterday online in the New England Journal. Dalcetrapib, the weakest of the CETP inhibitors, does nothing on LDL and raised HDL successfully, but did nothing on outcomes, apart from raising blood pressure a bit. The other drugs don't raise blood pressure, and we're talking about anacetrapib and evacetrapib. However, they do reduce LDL, as you can see from the top graph, by about 40 to 50%. So maybe these drugs will actually work, not as part of any action that they have on HDL, but maybe they'll just work because of good old-fashioned LDL reduction. It won't be the first time we've used the right drug for the wrong mechanism. So what would I conclude? Statins are still the mainstay of treatment. I think targets may not be necessary. We've heard that certain forms of diabetes are high risk. We know cardiovascular disease is at high risk. Well, why don't you just dial up the dial to maximum? You know, we all like the dial that goes to 11, don't we? And with statins, we can do 11. We can do a atorvastatin 80. We can do a rosuvastatin 40. Get away from a whole load of other things. Maybe if we need a target, we should use non-HDL. I think it's easier, simpler, far more reliable. High-dose statins for high-risk patients. Lipids for compliance. Do we have any evidence for anything else? Not at the moment. Where are we going to see a market for all of these other drugs? Well, in the people that we can't get down successfully. So familial hypercholesterolemia, in the groups which are difficult to treat, the people with chronic renal disease who have terrible lipids, the people with diabetes and nephropathy often have terrible lipids. So those are the groups. But where are we doing the trials? Where are I seeing? It's acute coronary syndromes again. Please, let's do a proper non-HDL trial in high-risk secondary prevention, i.e. diabetes with coronary disease. The numbers are small. You get an answer in 3 years, and we won't need to run around just going after surrogates. Thank you very much.